Please come back. In the meantime, we'd like to invite Dr. VASAVADA, who requires no introduction, world-renowned Indian in all fields, not only in our community of ophthalmologists. He is one of the most powerful person in the country, and he's been a teacher of teachers. He's been teaching us for so many years in regarding cataract surgery, not only handling surgery, how to handle people, how to teach students. His all points are so clear and so important to us. Dr. Abhay, please.
Thank you, thank you. Thank you, Jivans, for so much kind words. This is my financial interest, but I just want to make a caveat here, and there are two caveats. One is that we all do, there's nothing like premium and non-premium as far as the surgery is concerned. Every surgery we do is one way only, and all of us do premium cataract surgery. So do not get kind of wrong ideas. We all should do, irrespective of the IOL we perform as far as the cataracts removal is concerned, we want to do the same way. When you're doing it, forget about what kind of IOL you're doing it. So stick to the basics. And although the clear cornea day is not enough anymore, from what we heard, it's the starting point. In other words, we need to perform such a way that then next step of implanting, whatever IOL you're putting, will be the right, you're creating the right platform. So continue doing the surgery the way you are doing, and you can refine it. And I took many years to refine it. I'm still refining it. But whatever you do, it has to be safe, effective, and also predictable. All the time you do, you need to expect that clarity, mechanical outcome, the refractive outcome, and so on. And you need to customize for each type of cataract, each type of patient, each type of lifestyle, and so on. I'm taking an example of a soft cataract, and I've taken it as a surgeon because four-quadrant technique still is the most effective technique in the world. Forget about CHOP for a minute. It is universally applicable to every kind of cataract. So if you are doing four-quadrant, don't feel that you're doing a second-grade surgery. Four-quadrant is wonderful technique. Only change and only thing you want to keep in mind, and look at to the right side, the bottle height should be very low. At the moment it is about 48 centimeter bottle height, 30 IOP. Flow rate is very low because I won't mind even if I go through this bottom plate, I'm not going to catch the capsule because my flow rate is so low, it will never attract the posterior capsule. So in other words, with the low parameters and lower the as you go down in the depth, further decrease the parameters. So four-quadrant is a wonderful technique, particularly for soft cataract, but if you mastered it, it's for every cataract. Just keep in mind the energy that you spend, but in general, four-quadrant is something you must know how to do it safely, is using the appropriate parameters. But when you have a dense cataract, the CHOP technique has a great advantage, and direct CHOP is more effective than any other kind of CHOP action. However, it is little skill demanding. You need to place your chopper underneath the axis. If it is small, it's difficult. And also, you have a risk of going in front of the entry capsule and damaging the zonules. But whatever the CHOP technique you have, and you have multiple options, many of us sitting here have their own technique, and they are all wonderful. But remember, some of these cataracts would need extra chopping maneuvers, which I called as a multi-level chop. And all of these guys here, experts, do that already for years. So create a crack, take it to the level as you can, take the probe out and reinsert again so that your divisional forces are nearer to the bottom plate that you're working. If you try to divide the bottom plate for separating, you need to produce a lot of lateral separation to extend that crack. Instead, bring those divisional forces to the bottom plate. That's what the multi-level CHOP principle is, and that this video illustrates. This is a one-eyed loss with the pseudo-exfoliation glaucoma, and this is a pseudo-exfoliation eye. We initiate the crack and do not produce too much of blood. I go back again, took the phaco probe out and went into the depth again, and then I put that chopper into the depth I created, so my forces to the bag and zonules are minimal. So whatever you think appropriate to that particular case, you do that. And you must have more than one way of dividing this 4-quadrant, this technique, that technique, whatever you have. This is one more example of the dense cataract, and you can do horizontal chop also in a multi-level plane, or the vertical kind of chop, whatever you want to do. So this is an extremely hard cataract, leathery cataract, as you would expect it to be. And I tried to some extent division, but I'm not going to try like that. So I've re-impaled, I've buried it again into the depth. I took the probe out from that place, buried it again somewhere in the depth, nearer to the bottom plate, and then I'm able to produce that crack with the same force. I'm not increasing my separating force with my hand. And other thing I've learned when you want to achieve a clear cornea day one is this. This is the only single step that will ensure that your cornea is clear, and that is the plane at which you remove the fragment. The amount of energy is important, the time you take to deliver the energy is important, but the most important of the third is this: at what plane you are removing the fragment, and if you remove it near to the cornea, your cornea will not be clear. So be conscious once you divide the fragments where you do that, and that you need a good microscope with good depth. But if you use the high flow rate, means high aspiration flow rate, you cannot work near the posterior capsule, because high flow rate will attract the posterior capsule, you will rupture the capsule. So inadvertently or without your knowledge, subconsciously, you will end up taking the probe up to the cornea as more and more posterior capsule get exposed. As the fragment gets removed, without your knowledge, you lift the probe away from the posterior capsule, because your flow rate is killing. So instead of that, keep the probe right up to away from the endothelium, but reduce the flow rate, reduce the vacuum. So low bottle height, low flow rate, and we showed that in our clinical randomized trial published in 2010, 12 years ago, that it works well. And Jeevan Tithyal is the #1 surgeon using and exploiting the intraoperative OCT to the benefit of the patients. I try to copy that, but I can't that well. But you see that if you're conscious of the plane, you will be able to control that plane. You will see on the right side sometimes the fragment coming near to the endothelium, although on the video you will never be able to judge. From the microscope, surgeon doesn't know that if you're not mentally thinking about it. But I want to take a minute for that technique, which is in a step-by-step manner. Position the aspiration port underneath the anterior cortex, and you can see that in the animation there. And then second step is to occlude it, and then you occlude it with some degree of foot travel, 100, 150 vacuum. That will detach sorry, I'm not able to occlude that with 100 sort of thing. The cortex will come into that. If you see the animation, the cortex is occluding the aspiration port. And then this is the most important step, the third step. Displace it posteriorly. That's why, because anterior capsule is epithelium, and the cortex is attached to the villi of the epithelium. So you need to detach it ergonomically, taking it posteriorly. If you pull it radially, it will detach, but it will need a more force. So taking occluded tip little bit posteriorly to detach the anterior cortex from the anterior capsule, and then swipe. And Alan Crandall and Liliana Werner showed how traumatic it is to the zonules. And also then finally aspirate. Somebody showed us in this animation that if you do a conventional radial pull, it works very well, and I did it as a rut for 40 years. But then I realized, and he taught me, that if you do radially, sometimes you leave behind epithelial cells because you pull with the force. Instead, if you go slow on your foot paddle, take all this step by step and swipe, your chances of removing the epithelial cells are more, and that will be shown later on in the capsular opacification. Femtosecond assisted surgery is good. I'm not going to spend more time here, but if you want to achieve an outcome, sometimes you can combine that with that. So It is a lifelong learning attitude, and I'm still learning from my children and my fellows and trainees. And the key I learned, which I'm losing now, I had this, but I'm losing patience now. I'm getting more short-tempered. I want to be quick there. Don't do that. Don't do the mistake that I'm doing. Keep taking. It's a black cataract. Don't look at the clock. Look at the calendar. So finally, remember, patients are at the heart of all that we do. So surgical principles are same irrespective of the IOL you're going to put, irrespective of the VIP or non-VIP patient. All patients sitting under your microscope are same. You're going to do the same, and I am glad that all of you are doing the same way. Thank you.
Thank you so much, Dr. VASAVADA. You couldn't have transferred more pearls to us in the short time given to you. Next, we have another stalwart professor, Dr. J.S. Titial, who is humility, knowledge, academic, surgical excellence, and a superb speaker. Every time I listen to him, I'm left with some pearls that I keep and employ the next day. He's going to be talking about a very important topic about when to avoid premium intraocular lenses. It's not that every patient is a good candidate for a multifocal intraocular lens or maybe even a toric intraocular lens. And to take us through that, we have none other than Dr. Titial.
Good afternoon. Thank you, Dr. Ramamurthy, sir, for involving me in this particular very, very important topic which we are talking, premium IOLs. You heard so many other speakers talking when to put, how to put, which are those considerations which makes patients suitable. But job would be much more important, where we have to decide when not to do.